Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everyone, and welcome to episode number 85 of the Better Health Guy blogcast series. Today's guest is Dr. Neil Nathan, and the topic of the show is toxic. I introduced Dr. Nathan in episode number 19 with a more formal summary of his bio. For this podcast, I want to be more informal and just say how much I value and respect Dr. Nathan and the work that he does to help those of us recovering our health from chronic illness. Dr. Nathan has been a mentor to me over the years, and I'm always grateful when there are more opportunities to learn from him. I appreciate that Dr. Nathan has never accepted the toolbox that he has available and that he continues to look for new and better options to help his population of chronically ill patients. While his toolbox is quite large, he's still looking, still searching, still open to new and different approaches. Until we have all the answers, this is the type of doctor I think most of us would want. In his new book, Toxic: Heal Your Body from Mold Toxicity, Lyme Disease, Multiple Chemical Sensitivities, and Chronic Environmental Illness, Dr. Nathan shares his wisdom, experience, and toolbox with all of us. It is profoundly enlightening. And now my interview with Dr. Neil Nathan. I am very excited today to have Dr. Neil Nathan on the show. Dr. Nathan is only the third person that I've had on the show more than once, and it's a great honor to have him on the show today to talk about his new book and how he's approaching treating some of the most complex chronic illness patients. Thanks for being here today, Dr. Nathan.
Yeah, my pleasure, Scott. Thanks for having me.
Let's talk first a little bit about the distinction between toxicity and sensitivity. So in the book, you talk about toxicity, where the body is toxic with specific substances. And then you talk about sensitivity, where there's a hyperreactive type of response to certain substances. So would you say that most of your patients are both toxic and sensitive? Can they be one or the other? And how do you differentiate those two?
As always, excellent questions. I think that for many practitioners, when a patient is hyperreactive to the things they're trying to provide, many practitioners don't make an effort to distinguish whether it's sensitivity or toxicity that's triggering it. Now, in truth, for most of my patients, it's both, but not always. And I think it helps to refine the way we are treating if we know with more precision what we're treating. So for me, sensitivity is a manifestation of a hyperreactive nervous system. The limbic system or other parts of the brain have become hyperreactive to a wide variety of stimuli: light, sound, touch, chemicals, food. Any or all of the above can be a stimulus so intense that the patient has difficulty dealing with it. It can even, if extreme, trigger some neurological events like dyskinesias or pseudoseizures or a variety of neurological manifestations, which actually can be very hard for even neurologists to define. They're clearly a neurological event, but when you do an EEG, you don't get true seizure activity. If you test in normal ways, you can't label it in a nice little way that you would like, where you could provide medications, for example. But it is a true, absolute hyperreactivity of that nervous system.
I know that you've even said that some people can be reactive to water, which is surprising to some people to hear that. They immediately think the person is psychological, psychosomatic, but that is one of the things that you've mentioned people can react to. What are some of the key sensitizing events or triggers that lead to a hyperactive nervous system?
Okay, let me just back up. When people are hyperreactive to water, Usually that's mast cell activation. In fact, if someone tells me that they will have flushing or hives or tachycardia or anxiety or any number of reactions when they drink water, that is the tip-off that we're looking at a very clear case of mast cell activation. And I want to distinguish that from the hyperreactivity of the nervous system, which can be mast cell activation, but can also simply be an inflammation of the limbic system. So,
very good.
Sorry for that.
No, that's fantastic. That's exactly what I want to try to understand better for listeners.
Okay.
So in those hyperreactive people, then, what are some of the triggers that you commonly see?
Well, first of all, the top two causes of that type of reactivity are either mold toxicity or Bartonella. Occasionally Lyme, occasionally Babesia, other infections, sometimes viral infections, other toxins can do that. During the recent fires here in Northern California, when smoke descended into the valleys and even as far as the Bay Area, almost all of my patients who are hypersensitive found themselves even more reactive because smoke is a trigger. Annie Hopper, for example, who put together an excellent limbic system retraining, and I know you've had Annie as a guest on your program, her original triggering was a combination of the fires in northern Canada coupled with mold exposure. So that's a common one, not always appreciated, but any chemicals can do so. But I want to come back to the key point. Mold toxicity, Bartonella. If you have someone who's super sensitive, please think about those two entities because the vast majority of the people that I treat, those are major triggers and they're treatable.
So when we say they're treatable, if we think about the toxic side of things, we'll talk more about this later, but people think about binders, detoxification. What are some of the types of things we might think about when we're treating this hypersensitivity?
Well, to beat a drum, and I'm going to keep doing it, number one, think about diagnosis. The absolute first thing that you want to do is what's causing this? And the reason I'm emphasizing that is that there are many approaches to treating the chemically sensitive patient or the hyperreactive patient, which are very helpful and very useful. But if you don't cure the cause, you're going to be spinning your wheels. That patient will improve, sometimes a lot, but they won't get well until you remove what's triggering it in the first place. At that point, they don't need to do any treatment. And so I think that's a key point that I'd like listeners to take in.
And when you say when you remove the original trigger, they don't need to do any treatment, is it not the case that in some scenarios we can maybe remove that trigger and still, as you talk about in the book, need to do some types of rebooting activities to get the body to now more correctly respond to the environment?
Yes. A key component of my book is to help both physicians and consumers understand that once the system has been stuck, inflamed, and unable, it can't always heal itself. So you may be able to remove the original thing that triggered it, and for many people, that's all they need. But for lots of other people, they need to literally reboot the systems that are stuck. And in my book, I lay out all the systems that this could relate to, particularly rebooting the nervous system, rebooting the immune system, rebooting the gut and the microbiome, rebooting the endocrine system, and so on. So each of the various systems can get stuck, and therefore you kind of have to look at that individual and go, okay, we're 70 or 80% better. What's not better, and what do we need to do to get that being back up to full operating, running?
So for the hypersensitivity side of things, it's removing the trigger and potentially then doing some of these rebooting activities that we'll talk about later.
Yeah, very much so. But I'm going to take a step back, which is for many of the most sensitive patients, they can't even begin treating until they quiet down that hyperreactive system. Their bodies are so reactive in a variety of ways. It could be a limbic dysfunction. It could be a mast cell problem, which is triggered in the majority of my patients with mold and Bartonella. So you have to spend time with the patient and understand why is this individual so reactive, exactly how are they so reactive, and literally pre-treat them to even get to point A where you can even begin treatment.
And one of the tools that you and I have talked about in other conversations that can potentially help there is the limbic system work, the DNRS, for example. I think I got really interested in DNRS in part because of your very positive comments about it. And so maybe you can comment a little bit about how does DNRS potentially help you expand your toolbox of potential therapies in someone who first comes to you in this very hypersensitive state?
Okay. Excellent and very important. First, a quick overview. Currently, I am finding the two major issues which overlap and connect to each other in the hypersensitive reactive patient are limbic dysfunction and polyvagal dysfunction. And we'll get to the other one later. And I simply want to take a step back for the listeners and going, as you think about what we're talking about, think limbic, super important, vagus nerve and associated cranial nerves, super important, and they both interface with each other in very important ways, but the treatments are different. So those are the two major areas that I think need to be addressed on those patients. To come back to what we started with. The limbic system is a complicated area of the brain that primarily has to do with emotion and mood, but it also has to do with cognition, the perception of pain, and energy. Now, all of those things are almost commonplace in all of the patients that we're talking about who have mold and Lyme and other chronic inflammatory illness. So if you think about it just for a moment, if the limbic system plays a role in all of those areas, it's important. And we're just beginning to understand how important. Just a historical step back. When I first started working with the Annie Hopper DNRS program, it was about 2009 when I was working with patients who were almost exclusively multiply chemically sensitive. And we were finding that her program was wonderful for those patients. And I think Annie would probably agree that that's what we thought it was for. That's what she developed it for. That's what we were using it for. Butch Schrader at the American Academy of Environmental Medicine was having Annie speak at their meetings on a yearly basis. Over the next few years, it became increasingly apparent that limbic inflammation and limbic effects were not merely in the chemically sensitive patient, but probably in the majority of our patients who were having inflammatory brain issues caused by mold and Lyme and co-infections and the things we're talking about. And in fact, it wasn't just an outlier for the MCS patient. It probably affects most of our patients who are suffering with cognitive difficulties, emotional upheavals, mood swings, and energy issues and pain. So I'm hoping that underlines the importance of understanding the limbic system and its role in our patients, because there are very few of our patients, I'm beginning to realize, who wouldn't benefit from some treatment that was along those lines.
Yeah, and it's interesting with DNRS. I think I used to say that in some people it was almost a miracle. And I can think of 3 people in the last few months that I can't use the word almost anymore, because they went from very unwell to quite well and quite functional just with incorporation of DNRS in their broader protocols. And so, you see that time and time again. The downside, of course, is that it does take time and people have to make that commitment. But I know you've certainly talked about some of the really amazing successes you've had with it. And you being a medical doctor, I think that said a lot to me, and I hope people will explore it in more detail.
Yeah, I would say it's a rare patient that I've treated that has not responded to it anywhere from moderately to phenomenally. And I can't say that about a lot of treatments.
Right.
Now, if we want to talk about this a little bit more, number one, the primary treatment that I'm familiar with is the Annie Hopper limbic retraining, which she calls DNRS, dynamic neural retraining. A number of my patients have trouble with that. As you've alluded to, number one, Annie really insists that you take an hour a day to do the program. Does that help? Absolutely. Can everybody do it? Not so much. Especially people who are unusually cognitively impaired, and I do see a lot of them, it's very, very hard for them to commit an hour to a program. They just can't mentally do it. And so I've encouraged those patients to do 10 minutes a day, 15 minutes a day with benefit. There are other programs with which I am less familiar. Ashok Gupta has an amygdala retraining program that is, according to my patients, gentler, and that he allows patients a whole lot of leeway in terms of getting into it slowly at their own pace. You don't have to think about doing it an hour a day. And for some patients, the message, and I know it's not intentional on the part of Annie, for some patients, the message is, if I can't do this perfectly, I'll never succeed at it. And it becomes a stressor that adds to the problem rather than the solution. So it's important that as we work with our patients, we guide them into some form of limbic retraining that they're comfortable with, without any proviso that you have to do it perfectly or it won't work for you, because that's simply not true.
Beautiful. Let's shift a little bit now from the sensitivity side to the toxicity side. So I'm interested in your thoughts on the role of binders, how they help us to minimize that recirculation of toxins. And then you've talked in past conversations about the difference between absorption and adsorption. And so I'm wondering if you can kind of share that distinction with our listeners.
Sure. Okay. Now, toxicity simply means that there are literally toxins in the body that overload that being's ability to get rid of those toxins. A technical way to say it, their ability to detoxify is compromised. And ironically or tragically, both mold and Lyme and Bartonella toxins interfere with the body's ability to detoxify, so that they create that whole detoxificational issue in spades. And therefore, whenever we're working in this field, we need to be as gentle and as specific as we can for each patient. So one of my issues with the word toxicity is that it's a current buzzword, and people throw it around very casually as if all toxins are kind of the same, and I know how to detoxify because I can use, say, modified citrus pectin. Okay, that can be used for detoxification for some things. Does it work for mold? We don't know. No one's ever tested it. So a number of practitioners are simply going with their comfort zone in using the detoxificational agents that they know, rather than make an effort to find out what are the best detoxificational or binders for each substance that I know that my patient has. And I want to emphasize that, because I don't think that's appreciated in a way that we need to.
So then let's talk a little about the absorption versus adsorption. What is the distinction there?
Okay. Adsorption is loosely binding a toxin to a binder. Let's use activated charcoal as an example because that's what activated charcoal does. It adsorbs, as opposed to absorbs, which means you actually bind something. And that's a real problem. I'm going to use this bind concept. The word binder is correct, but it gives the impression to people who hear it that that material is tightly bound to that substance and is simply going to be carried out of the body. That's not really what happens. Activated charcoal is a great example. So what it means is that toxin is lightly bound to the surface of the charcoal. Static cling would be a very good way to think about that. Another way is one of my patients has a wonderful analogy in that if you took a pile of iron filings and a big magnet and you stuck the magnet to the pile and you pulled it along a surface, over time, a lot of filings would fall off the edges. That means that you've begun the process of pulling toxin out of the body, but now you have free toxin unbound. It can be reabsorbed by the intestine, go back into the circulation. So literally, if you can't keep up with the binding process, you can make someone much worse by actually releasing more toxin than that person can handle. And that's a super important concept in our treatment.
So is that why some people don't tolerate larger amounts of binders initially, because they have this dropping off of some of those toxins that then causes a reaction?
Exactly. And it's not rare, as you know. You are the recipient of the "if some is good, more is not better" school of medicine.
Yes.
But that is a super important point. Many patients that I see have been given the right materials, be it, let's say, take mold, be it cholestyramine, charcoal, chlorella, clay, and they've taken it in fairly decent doses and gotten much worse. And they don't understand it. And that's because they literally are more toxic because they can't keep up with what's being released.
Makes sense. Very helpful. So you mentioned that you need to understand the toxin that you're attempting to bind and match an appropriate binder to that. So how do you go about that process? How do you attempt to understand what toxins that particular patient needs binding support for?
Well, we would start by identifying what toxins are in the patient. And take mold, for example. We have several different laboratories that can accurately tell us which mycotoxins are in that patient. Knowing that, we can choose binders that we know work for those patients. Now, there is published data that helps us to know that's how certain toxins are effective. It hasn't been studied very well, but actually, the Department of Defense back in the 70s and 80s was studying these mold toxins as potential biological warfare agents, and they did some of the best studies in humans that we've got. So what we know is if you have ochratoxin, that is best bound by cholestyramine or activated charcoal. If you have aflatoxin or trichothecenes, those are best bound by charcoal, clay, and chlorella. If you have gliotoxins, those are best bound by clay, Saccharomyces boulardii, and NAC. And as our laboratories are beginning to help us by being able to measure more toxins, we need to go back into the medical research to find out which binders work for those toxins. And
And that means that those maybe are optimal, but let's say if someone has ochratoxin, for example, maybe they don't tolerate cholestyramine for whatever reason. It doesn't mean that they may not still benefit from a natural binding agent. It just may not be quite as effective, correct?
Correct. But it behooves us to try to use even a tiny dose of cholestyramine. That's a very good example, Scott, because um, for example, the Shoemaker protocol recommends a whole scoop of cholestyramine 4 times a day as an optimal dosage. I have very, very, very few patients who could do that. So I will start my patients who are unusually sensitive on 1/16 of a teaspoon of cholestyramine every other day. And that is actually quite effective if I can find a dose my patient can take. Now, as you're implying, I do have a handful of patients who cannot take cholestyramine at any strength whatsoever. Just can't do it. So for them, I will look at activated charcoal or try to work around that. There's another binder for that, optifibrilline, which Jill Carnahan has found very helpful, and I have found that to be helpful as well.
That's the one from Zymogen for people listening, correct?
Correct.
Yeah. So let's talk then. Binders generally stay in the gastrointestinal tract. So how important is it for us to focus on the liver, biliary, gallbladder system in order to get those toxins from the liver into the bile through the gallbladder so that they can actually meet up with the binders? Could we be taking binders that aren't effectively working because the toxins are never meeting up with that binder?
Yes, we can. And I have to thank you for your interview with Kelly Holderman on that subject. Your Detox 2.5 was fabulous.
Thanks.
And addresses this subject better than I'm going to. Because basically, as I listen to your podcast with Kelly, I'm scribbling down notes as you're doing it. I'm going, boy, I could do a better job with this. Thank you, Kelly. This is really, really valuable information. So to answer your question, I am now adding the component of helping the patient to make bile better using things like phosphatidylcholine, ox bile, and I'm adding things that would help the gallbladder empty better using things like acetylcarnitine and things of that nature. So I'm going to give you a plug. Please listen to that broadcast. It is absolutely superb for understanding the role of the gallbladder and how we need to improve gallbladder functioning to mesh with these binders that are coming down the track to get an optimal result.
That's one of the things that I mentioned in the intro that I love about you is as much as you know, which is tremendous, you're still very open to looking for new and better and different solutions, which is exactly the kind of doctor that people need for these kinds of conditions. So kudos to you.
Thank you, Scott. One of my perspectives is I know how little I know, and I am terrified about how little some other doctors know. So that's the balance that I work with. I do know that I can help the majority of people who have been sick for a long period of time, but I want to help everyone. And that means that I have to keep learning. And there are so many wonderful seekers out there right now who are delving into the answers that I'd like to hope that lay it on me. You've got some thoughts? I'm listening.
So we've talked a little about now the toxins meeting up with the binders. Let's talk about things like mycotoxins, other ionophores that actually end up inside our cells. What are some of the things we need to do to get toxins that are intracellular out of the cell so that eventually they can hopefully meet up with a binder?
Well, the body does that naturally. I mean, the basic operating system is that if you've got a toxin molecule floating around in the body will transport that eventually to the liver so that it can utilize its myriad detoxification strategies to either bind it or change the molecule by methylating it, sulfating it, acetylating it, so that it becomes more soluble, so that we can either get it out through the gut or get it out through the kidneys. So that's a natural part of the body. The key is to assist the liver in doing its job, assist the gallbladder in doing its job, then to bind that to get it out. Now, there's one other way to do that intravenously, which I like a lot, and that's intravenous phosphatidylcholine, which can not wait for that toxin to get where it's going, but it will circulate in the body through the circulatory system. And if it comes in contact with a toxic molecule, the phosphatidylcholine will help to bind that material and help excrete it. So that's one of my favorite methods if one has someone in the area who can do it and can afford it.
And is liposomal glutathione one of the things that also helps in this process? Let's say we have mold toxins that are kind of stuck in the cells. Does the liposomal glutathione help to liberate that?
Interesting question. That is a two-edged sword. For some people, yes. For some people, intravenous glutathione is great. And for some people, intravenous glutathione will throw them under the bus. And you kind of have to work with each patient separately. For some people, oral glutathione is extremely helpful. And for some people, oral glutathione will do what it can do, which is to actually mobilize toxin. And if it mobilizes it faster, then that person's detoxificational pathways will let them operate. It'll make them worse. So for example, when we look at mold toxicity, we are using usually a urine test in which patients collect their urine and send it to the laboratories that we're using to check it out. And because patients usually have some difficulty with detoxification, we ask that they take glutathione before they do the test, and we ask that they take a sauna or a hot bath or something of that nature to sweat, so that this will mobilize toxin and it will actually show up in the urine in an amount that will reflect what's really going on. So when patients take glutathione as a part of that test, a significant portion of my patients are worse immediately. A single dose of glutathione is like, oh, I'm worse. Because it's doing exactly what we're talking about here. It is mobilizing that toxin, but at a rate that patient can't work with. So is glutathione helpful? For some people, wonderful. For some people, not a chance. Do not go near it.
So let's talk now about mold and biotoxin illnesses in general. I'm interested in your perspective on the genetic predisposition side, the HLA-DR piece. How relevant is that in terms of your potential predisposition to developing a chronic inflammatory response syndrome? And then maybe the same, maybe differently, how relevant is it in terms of your potential for recovery?
Okay. It's not difficult to measure what we're currently doing, which is an HLA-DR. It's a relatively simple test. The question is, how useful is that information? And I don't think we know the answer to that. Dr. Shoemaker has emphasized that it is critical to understand that information to know who to treat and how and why. I have not found the same, and neither have a lot of my colleagues. And let me go over that answer in more detail. The easy part is for treatment, I have not seen it make any difference whatsoever. Meaning, if you have a supposed bad genetic profile that in no way affects your ability to get well with treatment, and it has not even made a difference in who gets better quickly or not quickly. I've seen it have no relevance whatsoever, and a large percentage of my colleagues would agree with that statement. I think the issue is that I don't think that is enough genetic information to tell us who is genetically predisposed in a useful way. We thought it was. I don't think it is. So I personally have no reason to do that test anymore. It doesn't help me distinguish who can I help or not help. And in fact, my biggest concern is that patients who note that they have a genetic predisposition are worried that they are compromised, and they'll take that as a negative, and they don't need that. That hampers treatment. There's other genetic information, however, that is beginning to emerge that I think may be more relevant and something that we may want to be paying more attention to. I think you've done a program with Bob Miller.
I have, yep.
Yeah. Bob, I think, is on the leading edge of looking at the genetic information we get from doing SNP testing to determine which exact SNPs predispose people to having a biochemical difficulty with healing their mitochondria, detoxifying, processing iron, and dealing with hydrogen peroxide and its metabolism, which is very important in this arena. I've begun working with Bob in this area, and he has a chapter in my new book, which I will encourage people to look at. There we go.
There it is.
So for those of you who are finding this interested, let me plug my new book, which is simply called Toxic: Heal Your Body from Mold Toxicity, Lyme Disease, Multiple Chemical Sensitivities, and Environmental Exposures. It was, as you know, Scott, for me, a labor of love. I really think that there is a ton of good, new, synthesized material in that book that will really help a lot of people to understand what they have and how to approach treatment. Okay.
I agree. It is fantastic. Anyone dealing with mold or Lyme, I cannot urge you enough to go get this book. I mean, I've learned from you for years and still was just a page turner. I mean, it was just fantastic. So kudos.
Well, thank you for the page turner. I was thinking people could use it for insomnia if it became an issue. But thank you. So enough plugging. Let's get into the meat of all of this.
So the good thing that I heard you say relative to the HLA-DR side is when people have this idea that they're broken because of their HLA-DR, that in and of itself sends a message that may influence their healing even more. But what I'm hearing you say is it doesn't really matter that much, if at all, in terms of their potential for recovery, which to me is a very hopeful position.
That's correct. That is correct.
Okay, very
that
good.
is exactly what I'm saying. And so I'm urging, if you are sick from mold toxicity, bottom line is, I already know you're not able to handle mold toxin. I don't need a test to know what your genetics is. That doesn't help my treatment.
So let's talk then about environmentally, their home, their school, their workplace. What are some of the screening tests before you bring an IEP in and spend a couple $1,000s? What screening tests do you generally recommend to your clients for evaluating the potential of an issue from water damaged buildings?
Wonderful question, and very complicated answer. The first step in treating mold toxicity for everyone is to evaluate their environment, home, work, car, to be sure that there isn't any mold exposure in their environment. If there is, they can get better, but they cannot get well. Cannot get well. So that is a step that cannot be overlooked. It's a step that most people shy away from. It's expensive, it's difficult, it's fraught with error. The methods we have are not fabulously accurate. And for many people who are contemplating leaving their home, they don't want to be leaving it known that they were evaluating their home for mold, because then they have to disclose it to a potential buyer, and that frightens them. So the bottom, but it has to be done. So you can deny it for a while, but eventually you're going to have to come around to, let's take a look at it. There are three major methods of checking. The one that is the gold standard of the building industry is air sampling. This is, and you'll understand why in a minute, the worst. The concept of having the air in the middle of this room measured is a little bit silly because more mold spores have weight. They don't sit in the middle of the air unless you're stirring it up. They're on the floor. The heaviest mold spore is Stachybotrys, and that will, even if it was stirred up, that'll be back on the ground, on the floor in an hour. So if you want to get a reading that will not accurately show what's going on in your home, excellent. The reason, and you're seeing where we're going with this, the reason it's used as a gold standard in the building industry is that a landlord or a builder can take a sample from the middle of the room and tell someone with a straight face, I measured this and you don't have a mold problem. So if you have someone who is evaluating your home and that's what they're doing to measure it with, not so good. The gold standard, if there is a gold standard, is ERMI testing, in which you take a sample of dust from that room, vacuum it, and mail it to a company that measures 36 different species of mold by PCR technology, and we get a much more accurate count of what's going on. It's expensive. To do it in every room would be very expensive. And for that reason, and I don't claim to be in the majority, but I continue to find it useful, I like mold plate testing. I think it's a good place to start. And that's simply you take a Petri dish, which contains a medium that grows mold, and you take the top off the dish, you put the plate on the floor for 2 hours, put the plate back on, and see what grows in the next 3 to 5 days. After 3 to 5 days, if nothing is growing, it's not a perfect test, but it's a good estimate of what's happening. On the other hand, if you look at that plate after 3 to 5 days and it is ugly, get it analyzed by the company that makes the plate. 50% of those species on that ugly plate may not be toxic, 50% may be. So you really want to know what you're dealing with. The beauty of it for me is that, number one, ugly plates get patients' attention immediately. Many patients tell me, I know there's no mold in my house. And then they show me their plates, which they email me a picture of, and go, maybe I should rethink that. Second, it tells you with more accuracy which rooms you want to go over more carefully to do ERMI testing on. And usually that will correlate with water damage. If there were leaks in the basement, crawl space, roof or walls that leaked, a bathroom with a shower that leaked, those are the places you really want to take a look at to see, okay, has there been the growth of mold?
So for people listening, immunolytics is one place that you can get those plates. I believe those are one of the ones that you use in practice as well.
Correct.
Let's talk a little bit about the urine mycotoxin testing. I would say you were an early adopter of those types of assays in your practice. I think over time, you've commented before that you found them to be very helpful. So I'm interested in, maybe you can share a little with us about some of the options for urinary mycotoxin testing, why those have become one of your primary investigational tools, and then have tests of that nature replaced things like C4A, TGF beta 1, and so on in your clinical practice?
Okay. First of all, from my perspective, those tests are far more specific and accurate than the tests you mentioned at the end. So things like TGF beta and C4As, MMP9s, reflect a shift in chemistry. For example, TGF beta 1s reflect inflammation. It doesn't tell you what caused that inflammation. Could be mold, could be Bartonella, could be Lyme, could be other conditions, NR. So an elevated TGF-beta1 tells you you are inflamed. My patients already know that. So, okay, what am I learning from that? It doesn't point me in the direction that I need to go to really help them with what is inflaming you and how do I need to approach treatment. On the other hand, if I have a positive urine mycotoxin test, I know A, you have mold toxin in you. B, I know which toxins. And so I can be specific about how I tailor my treatment based on those toxins. For example, if you were loaded with ochratoxin, then I would focus on charcoal and cholestyramine or Welchol as my primary binders. But if you had gliotoxin, I would focus instead on bentonite clay, Saccharomyces, and NAC. Completely different binder treatment based on what I'm looking at. And I think that gives us a lot more specificity so that we don't load our patients up on things that they don't need. It saves them expense and allows us to really pinpoint what we're doing.
I know that gliotoxin was recently added to the profile from Great Plains with the Mycotox. Have you had enough of those come back yet to get a sense for whether the data you're seeing with that gliotoxin test is similar to what you've seen with other labs you might have used?
Okay, so let me come back to the first question you asked. You like to ask questions with many parts, so I'm gonna come back to those questions that way. First of all, there are two major laboratories doing the testing, and the methodology is different, and what they're testing for is different. So we have the RealTime laboratory, which uses ELISA technology, and we have Great Plains Lab, which you alluded to before, which uses a liquid chromatography and mass spec technology. They're very different. They give different toxins and in different ways. And having looked, the Great Plains test came out about a year ago, and I've had it, and as you know, I do a lot of work with them, and I've had a chance to run that test from a patient on the same specimen from both labs a lot. And what I'm finding is I get significant and useful information from both labs that are different. Depending on what a person's been exposed to, sometimes the Great Plains test is totally negative and the RealTime is positive in almost everything. And vice versa. I've seen both. So although it is expensive, if I want a really accurate portrayal of what I'm looking at, I really like getting both tests. It really helps me to know what is the best test for that patient. Now, if one lab clearly shows a lot more than the other, on repeat testing, I'll just use the one that's best. So it also helps me pick that out. I think that for many people, if they're only using one of those labs, they're not getting a complete enough picture of what's going on. And I know we're talking expense here, but this is such a devastating illness that I think it's worth the money to really know what you have and how to approach it.
And I think the expense side of it, I think the expense now to do both of them is actually less than or similar to what it used to cost just to do the real-time labs test, right? The cost on that has come down from what I understand.
And that's correct. Yeah. So the answer to your immediate question is the gliotoxin is so new that I have nobody that's done it that I can compare to real-time.
Okay.
It's too new.
How do you respond to the concerns or potential criticisms that are raised around urinary mycotoxin testing showing some mycotoxins and those toxins potentially being the result of ingested food that had mold or mold toxins and that excretion being completely normal and healthy? How do we differentiate that from a water damaged building exposure?
Wonderful question. And the answer is we have no idea. That's the simple answer. There has been no study that I'm aware of that measures how those tests reflect food that is ingested. Zero. And so we're operating on a complete lack of knowledge in that arena. I will give you some contradictory information to flesh out that answer. My impression, personally, and many people agree with me, is that ingested food plays a very small to minimal role in either causing mold illness or in affecting those tests. Most people who work in this field agree with me, but not everybody. Having said that, I had a conversation with Jill Carnahan just a couple of days ago in which she personally had a test run which showed a massive amount of ochratoxin in her. It was up at a level of 76. And for your listeners, anything up to 1.25 is normal. 76 is a high number. Mm-hmm. She thought it was related to eating a large number of nuts that she had gotten from a particular patch. She stopped consuming those nuts, repeated her test a few weeks later, and it had dropped to 4. Now, she herself is still treating and wrestling with mold toxicity, so it's not 0. She still has ochratoxin, but that's a huge gap. So that's the first reported test that I have seen that suggests that it may be playing a bigger role than I have appreciated, but that's just one example, and it's not enough to give us any science to work with.
And it's also just one of the mycotoxins that are looked at, one of them where the food may have more of a role than, let's say, the trichothecenes from Stachybotrys and some of the others that Great Plains looks at as well, that are not known to come from food sources, is my understanding, correct?
Yes, and that's correct. We are about to do, Great Plains has recently funded a small study where we're going to actually look at this, to my knowledge, for the first time. And I'm working with the ICI organization, where each of us are going to contribute 2 patients. And the study will be very simple. We're going to not eat any foods in a food group that is known to contain mycotoxins for 10 days. And we're going to collect our urines. Then we're going to pig out on all of the foods that we know contain mycotoxins for 10 days and repeat the test. And even though that will be a preliminary study, it is my hope that we will begin to ask that important question and answer it in a way that will be more helpful to our patients.
This is probably a good time to put in a plug for ICI. So the International Society for Environmentally Acquired Illness, it's ISEAI.org. I do encourage people to go to the website. There's a conference coming up in May of 2019 that I think will be fantastic as well. But if you're looking for information in this realm of mold illness, one thing I really like, even beyond mold illness, really biotoxin illness, one thing I like about this organization is the collaborations that are happening, just like Dr. Nathan just talked about, in trying to answer some questions using science, but really focused also on how do we help patients get better. So do check that out, ICI.org. One of the other areas where your approach is a little different, and I think is worth talking about, is this idea of colonization. So the idea that I could be in an environment where I had an exposure to molds that produced mold toxins. I could leave that environment. I could be in the safest, most pristine environment, and I could potentially still have a source of mycotoxin production internally from colonization of prior inhaled Aspergillus, penicillium, or whatnot. So talk to us a little bit about that colonization piece. And in your experience, how often does that need to be addressed for your patient to fully recover their health from mold illness?
Let me give you the bad news first.
Okay.
I would say that in my patients, 90% of them have colonized. And admittedly, I am treating patients referred from other doctors who are sicker, have been ill longer, more sensitive, and more toxic. So I don't claim that that is an average patient base. So I think there are 2 kinds of mold toxicity. First, if you have not colonized and you've been exposed to mold toxin, if you leave that environment, you will tend to get much better shortly. And then if you take binders to finish the job, you can completely get rid of those, and that's it. You're done. You're well. In my patient population, that might be 10% of my patients. For me, the majority of patients that I work with have had a compromised immune system, and I think that's the key here, Scott. Patients who have had Lyme or other illnesses, anything, fibromyalgia, chronic fatigue, where their immune system has been compromised, if they are then exposed to mold, their immune system is inherently weaker, and they are far more prone to colonization. And colonization means that those mold species start growing in their sinus and gut areas primarily, making toxin. So if you leave your environment, you're still not going to get well. Let me comment on some of the work that went into our understanding that. This work was promoted largely by our colleague Joe Brewer, who published a paper in 2013 in which he took 112 patients who had chronic fatigue syndrome and checked their urine mycotoxins. And lo and behold, 93% had a positive urine mycotoxin test, which is like, wow. He then analyzed those patients because many of them, from his perspective, when he analyzed their current living environment, they had no mold whatsoever where they lived or worked. And he's looking at massive amounts of mold toxin in their urine and going, how's that possible? If you're constantly excreting it, at some point you ought to be well. And that's when it really hit him that those patients had colonized. When he went back and reanalyzed their environment, many of those patients had been exposed to mold 5 years before, 10, 15, 20. And he then realized, it's in you. You're growing it. It's making toxin ongoing. And when he added an antifungal treatment to the sinus and gut area, that's when he began to get profound improvements. And he published 2 series of patients, one of which 100 patients who took amphotericin B as a nasal spray, and another who took nystatin as a nasal spray. And he showed 94% improvement in the first group, 89% in the second group. And from my perspective, that put our understanding that you need to be aware of and treat mold and candida that we are growing inside of us. We've got to treat that if we're going to get our patients well. And in point of fact, that catapulted my results once I started doing that. Got much, much better results across the board.
That's very helpful. Yeah, thank you. Another area that I want to touch on is MARCoNS. So this idea of staph that's growing in the sinuses, potentially reducing MSH, potentially creating biotoxins. What are your thoughts on how important it is to treat MARCoNS? And is treating MARCoNS the idea of using antimicrobials to eradicate it? Or I've seen some people more recently talking about actually using probiotics to shift the microbiome of the sinuses. So how important is MARCoNS from a clinical perspective in your patient population?
Okay, another fascinating question, which is quite controversial, as you know. My opinion came from when I was working with Dr. Shoemaker early on. He believed that MARCoNS was a key component to resolving patients' illness. And I treated my MARCoNS patients. I measured it in every one of my patients, and I treated it aggressively. Now, back then, aggressively is far more aggressively than we're thinking right now. That meant use triple antibiotics for a prolonged period of time and BEG spray. And what I found was my patients weren't getting better doing it, and I couldn't eradicate it. People would do this for 3 months, 6 months, 9 months, a year and a half, and I still hadn't cleared it out. And I'm very, very, very uncomfortable using triple antibiotic therapy for someone where I'm seeing no clinical improvement and no change in MARCON status. As we have studied MARCONs longer, and I believe this is felt by most clinicians, most of us have not felt that treating MARCONs made any difference to our patients clinically, except to a certain degree, a number of patients with either chronic running nose or stuffed nose did report that they breathed better after doing some 6 weeks of MARCONs treatment. Otherwise, I've seen it have no effect on the total overall picture, and I do not think it is necessary. In fact, it's so ingrained, I'm not sure it can be treated. I mean, and that has been the experience of most people working in the field, is you can treat this aggressively till the cows come home, and it's still there. Or you get one nasal swab where it's clear, and you repeat it in 6 weeks, and it's back again. So I'm not sure it can be eradicated. I don't know that it should be eradicated. I don't think that it makes a difference.
One of our listeners wanted to ask some questions around VIP. So how successful has VIP been in your patient population? And then question, which I think, again, it's probably more of a concern, and hopefully your answer will give them some hope. The question was, do you feel people can ever fully recover without VIP?
Yes. Simple answer. I think VIP for some people can be an adjunct. And now I'm going to recount that answer in more detail, because I think this will be useful for not only VIP, but I'm going to throw LDI into this mix. Okay? You know, as clinicians, we are profoundly influenced by our first few patients that try something. We shouldn't be, but we're human. And so when the first few people we give something to do really well, we go, wow, this is the greatest thing since sliced bread. I love this stuff. And God has a sense of humor, so that sometimes those clinical benefits don't continue to manifest, but we tend not to see it through anything other than those rose-colored glasses that we started with. Basic human nature. As a clinician, I am as prone to that as anybody else. When I started with VIP, I did see initially some very spectacular improvement in quite a few patients. I would have estimated that at that point at 30 to 40% of my patients. Continuing, and I've been doing this for years, continuing to look at my results, I do not see that level of improvement to anywhere near that extent at this point. I'm now seeing some improvement, rarely spectacular, in maybe 10% of my patients at best. And so it went from fabulous on my hit parade as a way of rebooting the system to, I'm not convinced that it works as well as advertised. Many of my colleagues might take exception. I'm merely relating my own clinical experience. But I'd like to add LDI to that, okay, because I think it's apropos. The same thing is true for me with LDI when I started working with it. My first few patients who took LDI did spectacularly well. And I went, oh boy, another thing greater than sliced bread. Sliced bread gets a lot of press in some circles. And looking back over my results in the last year, I just haven't seen that kind of improvement with very many other patients. And again, I would put improvement somewhere in the 10% ballpark. And so I went from being a big-time advocate of both VIP and LDI to they are useful adjuncts, definitely helpful for some patients, but it isn't going to be your answer, not generally.
Okay, let's switch gears to Bartonella, the other sensitizer beyond mold that you talk a lot about in the book. So talk to us a little bit about how you see Bartonella and Babesia in terms of how they present similarly or different in your patients, and what role they play in their condition? What are some of the telltale signs that you see in Bartonella compared with Babesia?
Okay. Now, again, this is a wonderful question because there is a difference in perception of both of those organisms on the East Coast and the West Coast. So on the West Coast, when we talk about Bartonella and Babesia, and we all nod and agree, we're all pretty much on the same page. And then we talk to people on the East Coast. Many of them flip it, which is what you are calling Bartonella, I call Babesia, and vice versa. Now that's fascinating, and I have no idea what to make of it, but it's an observation that I've made over the years. Having said that, where I live and practice, for Bartonella, we're primarily talking intense anxiety, depression to the point of despair, depersonalization, where you don't feel like you're in your own body, pain on the bottom of the feet, headaches that are basically occipital at the back of the head in location, paresthesias and tingling in parts of the body that you shouldn't get that particular sensation, and sensitization. People who become more reactive to chemicals, food, touch, light, sound, and urinary tract and pelvic symptoms, and gastrointestinal symptoms. Okay. When someone presents with that constellation, I'm thinking Bartonella. And for the listeners, you can get the same constellation with mold. So teasing them apart can be pretty difficult. That's where the urinary mycotoxins come in. If those are strongly positive, you could have both, but at least I know with more certainty. Testing for Bartonella is notoriously inaccurate. We only know how to test for two main species of Bartonella, and there are 27 known. So a negative test has not ruled it out. Interestingly, sorry for emphasizing the Bartonella for right now. Interestingly, the Galaxy test, which is a test specific for Bartonella that comes out of North Carolina, is rarely positive on the West Coast and much more positive on the East Coast. So we may be seeing different species that we're not quite able to identify yet, and eventually we might get better at that. Switching to Babesia. For Babesia, the primary symptoms are sweating, particularly night sweats, frontal pressure, meaning a pressure, not necessarily a headache, in the front of the head, some psychological issues. There's a symptom that my friend Wayne Anderson calls a disconnect neurologically, where if you want to touch an object, automatically, for most of us, we just think, I want to touch that, I can do it, I don't think about it. With the neurological disconnect, that individual has to really think about how their fingers are going to move to this point. It's like they're not totally aligned in their body with that particular perception. And some psychological issues can also occur with Babesia. Profound cognitive issues is a bit more common with Babesia. So, I mean, those are some of the main separating differences.
So you talked about teasing these things out. I'm wondering if you can just give us a kind of high-level summary of how you do a provocation test using herbal or other materials to give you, as the clinician, more insights as to which one of these microbes might be a dominant focus for a given patient.
Yeah, and I do use the provocation tests a lot. I find them very useful. They're actually more accurate, more useful, and somewhat better than the laboratory testing, which is really inaccurate. So I use two different lines of tinctures, one of which is the Beyond Balance tinctures. I like BAR1, BAB1, and BB1 as my testing for Borrelia, Lyme, Babesia, and Bartonella. And I also like the Byron White tinctures, A-Bart, A-Bab, and AL complex. The tinctures are different, as you well know. Some of my patients who are sensitive cannot tolerate alcohol, which makes the Byron White tinctures less useful. The Beyond Balance tinctures are made in glycerin, which are gentler and generally better tolerated. But either of those, what I typically do is start with 3 to 5 drops of that material. Let's say Bartonella. I can either use Bar 1 or A-Bart, and I will give 3 to 5 drops of that twice a day for 2 days. If someone reacts to it fairly immediately, we stop, test over. A reaction means an exacerbation of their normal symptoms. If they become more fatigued, more brain fog, more anxiety, more pain, okay, that particular tincture has triggered an exacerbation, and I'm fairly comfortable that this is a player here, and I need to take that into account. So that's how I use it. If 5 drops won't do it, I'll go to 15 drops, I'll go to 10 drops, and 15 drops, and sometimes 20. And if I get no reaction whatsoever at 20 drops of that tincture twice a day, it doesn't take it completely off the table, but it goes to a back burner.
Do you have some patients where it's not necessarily an increase in those symptoms, but that they just go, wow, I went on A-Bart and I felt things improve?
Yes.
And is that still considered a positive provocation?
Yes.
Okay, very good.
Yes. Rarer, but yes.
In your experience with Bartonella treatment, do you feel like it can be treated with some of these natural compounds that you just talked about? Or do you think that there's, generally speaking, a need for some pharmaceutical interventions as well?
Okay. Listeners are not going to like my answer. Rarely do I see someone completely get over Bartonella unless they add antibiotics to their treatment. I love supplements. I use a lot of them. I find them very, very helpful. But as a standalone treatment, I rarely see that adequate. Bartonella is a really nasty infection. It is, for listeners who have not read Stephen Buhner's books, Stephen Buhner does a phenomenal job of getting inside the bacteria from its perspective of what it's doing in the body. And he does a beautiful job with his book on Bartonella, helping you to understand what it wants from its host, how it is operating, because if you do understand that, that can help orchestrate treatment. Now, Bartonella is, like Lyme, an intracellular infection, meaning it can hide from the immune system by burrowing inside of cells where it is much less reactive to anything you give it. And that's where the Beyond Balance and Byron White tinctures come in. Those particular tinctures, I believe, help to push the bug out of its intracellular location so that the immune system and the antibiotics and the herbals that you're using have a much better shot at it. But I don't see people getting well unless they use antibiotics, sometimes, unfortunately, for fairly long periods of time.
Very good. That's helpful. Let's talk a little about mast cell activation syndrome. And I know we're coming up on just a little over an hour already, so I'm going to loop a few more questions together and then just let you go with it. So,
how you do go on.
So with mast cell activation syndrome, how common is it in your patient population? What do you see as the primary triggers? And what are some of the treatment interventions that you find helpful for your patients?
Okay. There's a chapter on it in my new book. How's that for self-referencing? But it's extremely common in my patients. Bartonella and mold are primary sensitizers of mast cells. They will set off the illness so that mast cells become hyperreactive. Once that happens, that adds immeasurably to the whole clinical picture. Mast cell activation can mimic mold toxicity, Bartonella, Lyme, co-infections. Every single symptom that we might be talking about can be triggered by mast cell activation. And if I have someone who's unusually sensitive, this will often push them over the edge in terms of not being able to handle anything. So I want to be looking at mast cell activation early on. And to specifically answer your question, Scott, I'll usually say that mast cell activation is present in at least 50% of my patients. So common that I look for it in everybody. The tip-off for me is a symptom that occurs within minutes of eating, be it sweating, palpitations, hives, itching, diarrhea, abdominal pain, cognitive difficulties, fatigue. If that comes in within 15 minutes of ingesting anything, liquid or solid, there's your hint that you're dealing with a mast cell activation. And when I get that history, I know that I need to address that sooner rather than later. And for some of my patients, in addition, we had talked about doing limbic retraining early on. This is another thing that needs to be done early on. There are tests for mast cell activation, which are very difficult to obtain accurately and highly unreliable. So there are some doctors who won't treat it unless the tests are positive. I think that's a mistake because getting those substances that we're looking at, it's like taking a snapshot. In other words, once the mast cell has been triggered, if you don't catch that moment in time biochemically, you're going to get a negative test even when it's still hanging around. Having said that, therefore, what I do is I treat, and I have a kind of a two-step process in treating to clarify what I need to do. I have found that most patients prefer either supplement treatment or pharmaceutical treatment, occasionally both. So my first step is to use some from each category and see what my patient prefers. So I will typically start with quercetin as my favorite material. Now here's the deal with quercetin and many other things I'm about to talk about. It's really important that the patient take it 30 minutes before they eat, or it's not going to do much. If you think about it, you've got this activated mast cells, a large portion of them in the GI tract, and if you don't quiet them down before food starts coming down that alimentary canal, they're going to react. So we typically recommend 30 minutes before a meal that you'll take your quercetin, and that's my starting material, 30 minutes before each meal and at bedtime. I will then often add either Claritin or Allegra, first with an evening dose, then adding a daytime dose. You know, Claritin and Allegra are what are called H1, histamine receptor blockers, and then I will add an H2 blocker like Pepcid or Zantac. And when I start saying that, I get a whole lot of, oh my God, you can't stop stomach acid production with your H. And I go, these are not proton pump inhibitors. They will not shut it down. And what I need to see is to what extent does my patient respond? It's a trade-off. And if I can get a quieting down of their mast cell activation quickly, it's worth doing. If that particular part of treatment is not immediately effective, we're done with it. Once we've looked at those, then I will move in the direction that seems to work best. If they like pharmaceuticals, I'll usually add ketotifen or cromolyn sodium. If they like quercetin, I will add all clear, DAO, and paramine. And there's a new product that Beyond Balance has helped me with this.
Masties.
Masties. I've only had a chance to use it in a couple of patients, but again, these are the things that I'm looking at for response. The more of them a patient can handle, the better they'll be. And when you've got a mast cell activation, generally, if they will be responding to this pretty quickly, meaning within a couple of days, many patients say, whoa, I am really better. And I would add trying a low histamine diet. There's a whole lot of low histamine diets. They're quite restrictive. And I will typically tell people to go through the internet, find one that looks doable for you, do it for 2 weeks. If you're clearly better, stay with it. If you're not, don't keep working at it.
Let's talk a little more about the rebooting process that we talked about earlier, the different systems of the body that need to be rebooted. Is there some connection between the need for rebooting and the cell danger response in this kind of hibernation state or the fuse being blown state? Is there a connection between those two concepts?
Absolutely. They are one and the same. In Dr. Navio's work on the cell danger response, he has brilliantly put together an understanding of how, almost as a primitive response, when a cell feels threatened, it shuts itself down so that it can limit damage to the body, and it won't come out of that response until it feels safe. And you can't fool it into feeling safe. You can't trick it into feeling safe. It has to biochemically know it's safe for that to happen. And Dr. Navio has worked with a particular medication called Suramin, which is a purinergic binding agent, receptor binding agent, that has dramatically reversed autism, for example, in a wonderful pilot project that he has recently published. And we believe that it will be effective for many of the things that we're treating, and we have some research projects on tap to do that with. So now we're talking rebooting not on a cellular level, but on a organ level. So we're talking about rebooting the nervous system with things like the DNRS program that we talked about earlier, with things like treating the vagus nerve to settle down the polyvagal issues that arise, with things like lens, frequency-specific microcurrent, osteopathic manipulation, and the myriad of techniques that Norman Doidge talks about in his books. You had on Patrick Porter talking about brain tap, utilizing those techniques. All of those are, in my experience, wonderful, not just adjuncts, but necessary components of healing so that you can take a nervous system that is literally shut down and reboot it.
Is it reasonable then to say that mold and Bartonella are potential triggers of the cell danger response?
Absolutely.
Okay. One of the things with cell danger response that was intriguing to me is that ATP can actually be a signal for danger in that model, as I understand it. So
Yes.
my question is, in someone who's in a cell danger response mode, are things that stimulate production of ATP good things, or are they potentially bad things in amplifying the danger signal?
Okay. No surprise at my answer. It depends. It depends on where you are in the process. The mitochondria are affected in everybody. And so when I hear the generic mitochondrial dysfunction diagnosis, forgive me, but I roll my eyes because everybody has that. That's not an answer. That's a description of what's happening, and it doesn't really add to what we're doing. Unfortunately, when people hear that, they immediately rush to, well, let me give the mitochondria the nutrient supplements that will improve it. Let me give it L-carnitine and taurine and D-ribose and CoQ10 that we all know work. The problem is when the body's shut down, you can't use it. So as a general rule, you can do that all you like, and you're going to see very little response in your patients. However, once you have fixed the trigger, once you have gotten rid of the mold, or cured the Bartonella or whatever. Now the body can take those materials and run with it. And so what Dr. Naviano and I have had long discussions on this subject, and we are in pretty much complete agreement that once the body is not in danger, because you fixed what put it in danger, now you can reboot it by giving it the things it needs.
It sounds somewhat similar to what you've shared in the past around methylation, right? That if you start supporting methylation too early, wrong time, you might have some negative consequences, and that maybe even methylation issues are the body's intelligent adaptation to be a protective mechanism.
Yeah, very much so. Methylation is one part of the cell danger response in which the body intentionally shuts down methylation so that foreign invaders, say a virus, viruses can't reproduce without hijacking our methylation chemistry. So we intentionally shut that down as a primitive response to not let foreign invaders use methylation to grow. And so, yes, you're not methylating when you're sick, in the same way that you have mitochondrial dysfunction. Virtually everybody who's been sick for a long time doesn't methylate well either. Rebooting it requires that you get further down the road. And that will vary from patient to patient. Some patients who are not completely behind the eight ball can start treating methylation early. Some people can't even begin to approach it until they're further along in their treatment.
A couple of concepts that are brought out in the book that I'm going to leave to the book, but think are important for people to go and read about, is the idea of carbon and monoxide being one of them, porphyria being another that you go into a lot of detail about. I think those are topics that people can also learn more about in a podcast on Lyme Ninja Radio that you did recently as well. I want to wrap this discussion up with giving people a little bit of an understanding about polyvagal theory and the concept that you've shared around specific breathing exercises that we can do very easily in a short number of minutes a day that can have a profound effect on this polyvagal concept. So can you tell us a little about that?
Okay, those two kind of different issues here.
Okay.
The breathing exercise was essentially for porphyria.
Okay.
And I mean, the issue in porphyria is that often the carbon dioxide level is so low that the body can't extract oxygen from the hemoglobin molecule until you actually raise the carbon dioxide level. And a lot of people think oxygen delivery is solely about oxygen, but the purpose of those breathing exercises, which I allude to in my book, there's a great book called The Oxygen Advantage that goes into that in more detail, where very simply you can train your body to raise the carbon dioxide level so you can use oxygen better. Now,
I thought there were some exercises people could do that had something to do with supporting this polyvagal theory as well. Is that not the case?
That is the case, but they're different.
Okay.
They're structural exercises specifically to relax or quiet down the vagus nerve and the four cranial nerves that are connected to it.
Okay.
And so there's a wonderful book called Accessing the Healing Power of the Vagus Nerve by a body worker named Stanley Rosenberg. At the back of that book, he lists and shows very clearly 7 exercises that you can do that specifically quiet the vagus nerve. So when I talk about exercises, that's what I was alluding to.
Okay.
And that's what I'm promoting. I do, in the time we have, want to share with our listening audience that I think that the other huge piece of dysfunction that needs to be addressed in our chronic patients is that of the vagus nerve. And we have some new understandings of the vagus nerve and how it works. For years, we thought of the autonomic nervous system as basically being the sympathetic system, fight or flight, and the parasympathetic system, which is relaxation. And more recently, we've realized that the vagus nerve, which controls the parasympathetic part, actually comes from 2 different parts of the brain, which then fuse to become the vagus nerve. Super important nerve. It supplies most of the gastrointestinal tract, the lungs, the heart, really important. But it also is the primary regulator of the parasympathetic nervous system. And the piece that's new is the ventral branch of the vagus nerve is about safety. So let's weave back in the cell danger response to this discussion, because it does weave back in. We talked about how critical it was to convince the body that it's safe. Now, my patients, particularly the ones that are super sensitive, have not felt safe for a long time. The chemically sensitive patients, their environment is a walking minefield. They do not know who they will pass on the street that's wearing a fragrance that will set them back for weeks. So their nervous system has learned that nothing is safe for them, and accordingly, it's become hypervigilant. Eventually, that hypervigilance has backfired, so they now don't want to take anything. No supplement, no food, anything is suspect from the perspective of that nervous system. And if you don't quiet down that nervous system, they're not going anywhere. To a certain extent, that interfaces beautifully with the limbic component, but it is separate. So there are three major ways that I know of that one can treat the vagus nerve and quiet it down so that the body can begin to feel safer. It won't feel safe for a while, but it can't stay at that hypervigilant mode because it's just too hard on the body. It's exhausting. You can't ever rest because you just don't know what's safe and what's not safe. So the exercises that I mentioned at the back of Rosenberg's book, Accessing the Healing Power of the Vagus Nerve. Rosenberg is a craniosacral therapist, and so good craniosacral therapy can specifically help the vagus nerve and the associated cranial nerves to quiet down. And lastly, again, frequency-specific microcurrent has some frequencies specific for the vagus nerve to quiet it down. And combining some of those early on in treatment has really added immeasurably to my being able to help some of my sensitive patients and get them to be able to even get into the treatments that are ultimately going to cure them.
Beautiful. That's fantastic. So as we wrap up, I want to give you an opportunity to share a little bit with us about ICI, to talk a little bit more about the book, anything that you feel like we didn't cover that you want to highlight for listeners.
Thank you. I appreciate the opportunity. I love my new book better than anything I've ever written. No, I do. I loved writing it. It felt like I was writing it for people who really need this information. Scott's got it out there for you. Buy this book. And I hope it will be as helpful for the world as I intended it to be. In terms of ICI, it is a relatively new organization. I will encourage you all to go online, read about it. For healthcare practitioners, join. We are offering a certification program so that over the course of a year or two, we will teach you how to do this well enough that we hope that you'll be able to start and begin treating patients. There are millions of patients who need this work. It's not one or two. It's not a handful. There are millions of patients suffering with chronic fatigue, fibromyalgia, mold, and Lyme, and they need you. So if you are a healthcare provider and you really want to help your patients, please look into ICI, our annual meeting. Our first one will be May 3rd to 5th in Phoenix, Arizona, and we have a who's who of speakers. Bob Navio, Joe Brewer, Jeanette Hope, Richard Horowitz, Joe Burrascano, and the ICI crew. It's really a who's who of people who are in the mold toxicology and Lyme world, that we're all coming together to work together to share our vision. And I hope that you all take advantage of our efforts.
I'm personally very excited to see this collaboration of very bright minds unfold. I think the intention of ICI and the people that are bringing it together is really to help patients. And I'm very, very excited to see what happens over the next year. Already talking about some research studies. I think things like that will really enlighten all of us.
Yeah, I agree. When I was first invited to join the board, I just thought I'd be on the board because I didn't really want, it's not like I'm not working hard enough already. And I told the board, I'll be on, but kind of like a figurehead. I'm not going to do much. You know me well enough to know how that worked out.
Yeah.
I fell in love with this group of people. They're one of the least egotistical group that I've ever worked with. They're all seekers. We're collegial. We can disagree with each other in respectful ways. We can share with each other, and that's what we want to do on a global level. And I became so intrigued that, as I know you know, I volunteered to help put together this conference that's occurring in May, and also put together the certification process. And I am very involved at this point, and happy to do so. I've been on many boards. I have regretted that most of the time. This board is different. This is a group that really believes in what we're doing, and it's a joy to be a part of them.
Yeah, it's fantastic. Last question. What are some of the key things that you do on a daily basis in support of your own health?
Well, I think I answered that question last time, and I'm going to give you the same answer.
It's been a year.
It's been a year. How soon we forget. Having studied a large collection of spiritual practices over the years, I have boiled it down to 3 areas that are hard enough to do that's my spiritual focus. And it's be mindful, be present, be grateful, be appreciative, and to be of service. And just keeping my focus on that is plenty. To me, that is how I try to live. And, as imperfect as we are as beings, just doing my best. But I got to say, I'm loving my life. I love that I have the opportunity to do what I do, to help people the way I do. I'm married to the most incredible being. My kids are great, and I live in a phenomenal place.
I was going to say, if you had the opportunity to do a screen share, you'd put up a beautiful picture and you would say, "Eat your heart out, everyone."
Every chance I get. So, I don't know if it can get any better. I just want to continue doing it.
Fantastic. You have been, as I mentioned in the intro, a huge mentor of mine. I appreciate everything that you do. You really are a hero. I love the book. I love the information that you're putting out there, helping people, helping practitioners. It's so critical, and you have so many pieces of the puzzle that you've put together so nicely in this book and in the work that you do that really does translate to less suffering, happier, more joyous and fulfilled lives. And I just want to thank you so much for that, because you really are incredible.
Thank you. And I want to return the favor. Your podcasts have been phenomenal. For those of you who don't know, Scott prepares better than anyone I've ever seen. He sent me 5 pages of questions, which were not just 5 pages of questions, carefully thought out questions that really involve thinking and things you can go into. And these podcasts are phenomenal, and I want you to take a bow for how wonderfully you've done with these.
Thank you so much, Dr. Nathan. Look forward to talking with you again soon.
You bet, Scott. Take care.
Thank you. To learn more about today's guest, visit neilnathanmd.com. That's neilnathanmd.com. neilnathanmd.com. Thanks for your interest in today's show. If you'd like to follow me on Facebook or Twitter, you can find me there as Better Health Guy. To support the show, please visit betterhealthguy.com/donate. If you'd like to be added to my newsletter, visit betterhealthguy.com/newsletters. And this and other shows can be found on YouTube, iTunes, Google Play, Stitcher, and Spotify.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.